So my name is Helene Purcell. I'm from the University of Pennsylvania. You heard earlier from two of my co-authors. First was Namrata, who used the Malawi data, as well as Ileana, who was talking about the Ghana HCAT. And now we'll be going back to the MLSFH data to talk about hypertension and blood pressure trends that we've seen over the last decade. There we go. So overall, non-communicable diseases, or NCDs, are the leading cause of death worldwide. Over 40 million people die annually from non-communicable diseases, and which accounts for 75% of non-pandemic deaths around the world. 82% of non-communicable disease-related deaths are, of premature deaths or deaths under age 70 come from lower middle-income countries. And globally, there are 19 million deaths from cardiovascular disease, which is the leading NCD killer, the leading non-communicable disease, highest in mortality around the globe. And the highest predictor of cardiovascular disease is hypertension, or those who have high blood pressure. So 1.28 billion people are estimated to be living with hypertension. And as such, given all of these statistics, it is therefore the leading risk factor for mortality globally. It's defined as having a systolic blood pressure of greater than or equal to 140. So we usually hear 120/80 would be the normal threshold for blood pressure measurements. Hypertension would be greater than or equal to 140 systolic, greater than or equal to 90 diastolic. And it's an age-related disease where, as we age, the risk of developing hypertension increases, or as far as we know. So one of the biggest problems with hypertension is, despite its fairly easy diagnosis and the availability of treatment, only half of people, over half of people don't know that they have high blood pressure. There aren't always symptoms associated with it. And only 7 to 10% of people have their blood pressure controlled, which means that they are on treatment that is effective enough to lower blood pressure rates to normal levels. And when we turn to looking at what hypertension looks like in sub-Saharan Africa, in these contexts, we really have the double burden of disease. So not only have they been fighting infectious diseases for quite a long time, including HIV, malaria, but now there's a growing NCD epidemic, especially as there are treatments for infectious disease that have enabled people to live longer with HIV and AIDS and other infectious diseases. Therefore, we have an aging population and a higher risk of non-communicable diseases. And there's estimated to be over 200 million people by 2030 to be living with hypertension in Africa on the continent. As we would typically think in Africa, they have overburdened health systems and vulnerable populations in many countries, which makes hypertension even more of a concern. And currently, cardiovascular disease accounts for 13% of all deaths and 37% of all non-communicable disease deaths. On the continent totally, or globe, on the continent as a whole, only 27% of Africans with hypertension are being treated, and only 12 have effective treatment coverage. So these are quite low compared to the global levels. And many of the health systems in these contexts are, again, overburdened and not equipped to manage chronic diseases. They've really been set up to fight infectious diseases. And one of the biggest obstacles is just having people know their hypertension status before they even can engage with the health system and engage for treatment. And so in Malawi, we have the Malawi Longitudinal Study of Families and Health, which has a decade of blood pressure data among a rural aging population in Malawi. So the study itself, Namrata talked about this earlier, started in 1998 to study fertility, but the research goals have evolved over time. And in 2012, the mature adult cohort was formed, which included everyone from the MLSFH that was 45 years and older to study aging and health behaviors in aging trajectories among these individuals. So we have lots of data on health outcomes and behaviors that are measured longitudinally. And for blood pressure specifically, we have 4 different rounds of data. From 2013, we have 2 intermediary measurements, 2017 and 2022. And most recently, we measured blood pressure in 2024. And just a note about this, we were, as we went into the field and measured respondents' blood pressure, if they had registered an average of a blood pressure reading of between the 3 measurements that were done of greater than or equal to 160 systolic or 110 diastolic, then we would give the respondents a referral card to go and get an actual diagnosis from medical personnel. And the levels are much higher than the 140/90, just so that we weren't getting these intermediary that might just been a false positive reading. And we were really capturing those who likely had hypertension. And then, this population in general has had life course experiences that are typical for older persons in sub-Saharan Africa. There are moderate to extreme levels of poverty, and most have lived their lives, most of their lives with less than $1 a day. And so in this paper, we're trying to answer a few research goals and questions. Can we use our longitudinal blood pressure measurements over a decade to analyze trends and associations for behavioral associations for policy interventions? Do hypertension rates and behaviors typically associated with hypertension risk across hold across different contexts? So in this context, the low income context versus in Western countries. And are high income rates and determinants similar to what we see in rural Malawi? And finally, what are the mortality and other health outcome implications of hypertension in this context? And so just some overall summary statistics and a little bit more description of the sample. We started in 2013 with 1,200, a little over 1,200 respondents, and the longitudinal aspect of this cohort has continued into 2024 with a follow-up of, after a decade, of about 900 respondents, a little over 900. High level of mortality. It is respondents at older ages, so perhaps this would be more typical. But other than the mortality, we lost very few people to follow up over that time period. About 60% of our sample is female. That was starting from the beginning because we enrolled females and their husbands. And just generally to talk about some demographic trends, we have very few who have greater than a primary education and many that have no education at all. High rates of marriage, although there are some dynamics there with divorce and remarriage. And the overall HIV rate among this part of our sample is about 6% over time. And so if we disaggregate our blood pressure trends over both survey period, age group, and sex, what we find is that we have high average blood pressure. We can see here, if we look at the normal rate for blood pressure at 120 and then the hypertension classification at 140, we do see, especially in these older age groups, even at the average, that those are higher than this threshold here, and always higher than the pre-hypertension threshold as well. So even at the average, most of our sample is going to be at least pre-hypertensive. And if we look at the percentage of hypertension across these levels, we see that they are quite high and beat both the African rate of hypertension and the global rate of hypertension. However, over time, and I'll show this more clearly here, we don't see from 2013 to 2024 necessarily that hypertension rates are increasing over time. So while they are high, we don't see a lot of and cross-sectionally, they appear to be high. We don't see a lot of change over time in these. We don't see a drastic increase in hypertension over the 4 survey rounds. If we look, we also ask in 2013, 2017, and 2024 about diagnosis and treatment. And we can see that, over 50% have not been, so For those who are no hypertension, we can see that in dark blue here, but those who are hypertensive and undiagnosed in the yellow is quite a high percentage, especially in the 2013 baseline. We have diagnosed and untreated as a small portion, and diagnosed and treated but not controlled. They're on medication, but it's not effective enough to bring their blood pressures levels below hypertensive. We can see that those are smaller portions here. And there are no individuals in the sample that are able to control their blood pressure with treatment, diagnosis and treatment, which is notable here. So while we do see increasing levels of diagnosis and treatment, overall, these levels have not been enough to make our respondents less hypertensive over time. And if we also disaggregate hypertension by different stages of hypertension levels using the American Heart Association classifications, we see that not only are they hypertensive, but we have quite a few at hypertension stage 2, which would be over 180 over 120, or either systolic or diastolic above those thresholds, and even a decent portion that are in hypertension crisis, which is this dark blue or dark red here. And that over time, the levels of normal and pre-hypertensive are decreasing, while these levels are staying the same. And we do have, again, a high portion of these respondents who have died over time as well. But overall, not any striking gender differences between the sample, or between men and women in the sample. One of the most interesting results we've found so far are these hypertensive transitions. So if we look at those where the x-axis, sorry that I keep having to move these around, but if you started at baseline in 2013 with normal hypertension, and then we then remeasure your blood pressure in 2017, 2022, 2024, and across all 4 waves, and we look at how that transitions, we can see that there are, even among the normal blood pressure, that very few, only half of this over 4 years remains hypertensive, and even less when we look at the 10-year follow-up. And most strikingly, those who are hypertensive stage 2 and hypercrisis at baseline, by 2024, very, very few have become pre-hypertensive or normal, and there's a much higher mortality rate among these individuals. So we can see that there's transition into hypertension, but not much transition out of hypertension here, which is concerning. And this could also be a result of at age. As the cohorts age, they're more likely or at risk to develop hypertension. I'm actually going to skip this for time, but what we do find is that the only baseline associations with behaviors that are also related to risk of hypertension in 2024 is obesity, but that's not really explaining a lot of the hypertension rates, because only 4% of the sample can be considered obese, so it's not explaining too much. And then the only other thing I'll talk about here is just the mortality implications. So baseline hypertension in 2013 has a high likelihood of predicting the person who has died by the survey rounds of 2022 and 2024, with significant, where the only other significant associations are with with age groups, gender, and then also with HIV and AIDS, which might be expected as well. So there's a high risk of hypertension predicting mortality here. And the only other thing I'll say is that when we do measure health behaviors and outcomes in 2024, like things like our depression score, reporting of good health, grip strength, anxiety, and cognition, there isn't a lot of association with being diagnosed with hypertension at baseline and these follow-up measures, except for perhaps with self-reported good health in 2013, in 2024, some negative associations here. So overall, the conclusions that we've drawn so far, although it's still a work in progress, and I'm very interested in hearing everyone's feedback, are that in this context, there are high rates of hypertension. Age and BMI tend to be, or seem to be, the only significant drivers that we can find so far. We see very low transition away from hypertensive levels over time, over the 10 years, and that diagnosis and treatment levels are improving, but remain low. And even when our respondents are treated, they're not effectively having their blood pressure control. Not a lot of evidence for behavioral associations between hypertension and these behaviors. So therefore, perhaps the policy implications would be to focus on diagnosis and treatment rather than preventive or changing lifestyles. And this would align with some of Parati et al.'s work and some other work that looks at awareness, treatment, and control of hypertension in Africa. So thank you so much.